Assalamu alaikum everyone. This is Dr. Abdullah and good evening to the PSA Karachi online lecture series. Today we have Dr. Sheharyar Ashraf from Peshawar. Dr. Ashraf is currently working as assistant professor at Lady Reading Hospital and he also serves as general secretary of Pakistan Society of Anesthesiologists Peshawar chapter. Before we start, I request all the participants to kindly mute their mics and use the chat box to share your questions during the lectures, which will be answered post
No,
lectures.
no.
Thank you. Dr. Sharyar.
Thank you, Abdullah. Assalamu alaikum. I am thankful to, first of all, I would like to pay thanks to Dr. Asma and team for giving me the opportunity to deliver this important talk on topic of anesthesia concern and management for supratentorial craniotomy. I am equally thankful to esteemed faculty and doctors who take time out of their busy schedules for today. So let's start for the with the presentation. The tentorial part of the brain is a crucial dural fold that separates the cerebrum from the cerebellum and brain stem. The primary function is to protect the underlying cerebellum and brainstem from pressure exerted by the heavier supratentorial structures, that is, cerebellum, showing in this part. Um, It also helps to maintain the brain's anatomical integrity, prevent sagging, and the tentorium is also involved in the venous blood drainage and can be a site of herniation in cases of increased intracranial pressure. In the clinical features for the raised intracranial pressure, it often manifests as headache, that is dull, persistent, or a severe headache with nausea, vomiting. Vomiting, especially in the morning, may be related to increased ICP. Papilledema is a sign of increased ICP, may be observed on eye examination. Uh, Changes in the mental status, including confusion, disorientation, and lethargy, may be the neurological signs. And in the focal deficits, we may have seizures, which can be generalized or focal, and may be the first symptom of a supratentorial tumor. Weakness or numbness on one side of the body, reflecting damage to the motor or sensory pathways, visual disturbances such as visual field defects, blurry vision, diplopia, particularly if a tumor is present in the optic chiasma, and there might also be cognitive and behavioral changes. That includes memory loss, personality changes, or difficulties with concentration depending on the tumor's location and size. So let's comes to a pre-operative assessment. For supratentorial tumors, it involves evaluating the patient's neurological status, psychological well-being, and suitability for surgical procedures. Includes awake craniotomy if appropriate, and it also includes reviewing existing neurological deficits, the medications patient used, like steroids for seizure controls, and neurological assessment. Understanding the neurological disease and its presentation, uh, for that we may need to assess the motor, sensory, and higher mental functions, as specific neurological deficits depends that's mainly depend on tumor location. In evaluating cognitive function, neuropsychological and language assessments are crucial, especially for tumors near the eloquent areas that are responsible for speech, and motor function. And preoperative assessment may also include or predict intraoperative brain swelling, potentially using imaging techniques or physiological parameters like optic nerve sheet diameter or heart rate variability. And definitely, these patients need psychological assessment, as these patients are often experience significant anxiety, requiring extensive counseling and psychological preparation. And in cases uh, where we need or we planning for the awake craniotomies, so these patients must need to be cooperative, as they have to undergo extensive psychological preparations. In pre-operative medications, we need that we need for supratentorial tumors often include steroids, anticonvulsants, and other supportive medications to manage edema, seizures, and other complications. Specifics can vary depending on the patient's individual needs and the surgeon preferences. In steroids, we like to use dexamethasone. That need we need to reduce cerebral edema and inflammation associated with brain tumors. Anticonvulsants like levetiracetam or valproic acid used to prevent seizures. And definitely in every surgical procedure we need antibiotic cover, and other medications like analgesia, anti-nausea medications, and medications to manage blood pressures, and all the other anti-epileptics or hormonal therapies. And sometimes we also need diuretics in these patients. In pre-operative investigations that we do for supratentorial tumors, mainly our aim is to assess the tumors, their characteristics, and to know the surgical planning, how to operate these tumors. And definitely, we need to ensure patient safety. So these investigations includes CT, MRI evaluation. Definitely, MRI evaluation is crucial for visualizing the tumor, its size, location, relationship to surrounding structures, like if they are passing through the venous sinuses, or to identify any uh, perilesional edema around the tumor. So we need additionally neurological, beside from the neurological assessment, the blood test and other baseline investigations to determine the patient overall health and to prepare them for surgery. Uh, these patients usually having the problems with raised ICPs. So, to manage preoperatively their ICP in supratentorial tumors, we need to focus on stabilizing the patient, minimizing further ICP elevation, and to prepare them for the surgery. We definitely need the following strategies. In general, prophylactic measures, we need to ensure airway, breathing, circulation. In the airway, we definitely need to have a supplemental oxygen, and monitoring of the vital signs closely. Head of the bed elevation greater than 30 degrees in help to venous drainage to reduce the ICPs. We need a neck alignment to have a neutral neck position to helps the venous outflow. And for ICP monitoring, we need the fancy boards and other things to assess the effectiveness of interventions. We have a certain medications to control the raised ICPs. That includes osmotic agents like mannitol, hypertonic saline. These are commonly used to reduce cerebral edema by drying fluid out of the brain tissue into bloodstream. Apart from the osmotic diuretics, we have carbonic anhydrase inhibitors like acetazolamide, that is also used to decrease CSF production, potentially lowering ICP, especially in idiopathic intracranial hypertension. And definitely, we have sedative analgesics to reduce the anxiety and pain that may help to prevent or increases in ICP due to stress responses. Apart from these pharmacological interventions, we have another strategy, hyperventilation. By transient hyperventilation, we may lower the PCO2, that potentially reducing the cerebral blood flow and ICP, but use should be administered cautiously. So, apart from the general measures, the medications, the other parameters that we have to reduce the ICPs is CSF drainage through lumbar puncture, that can be used as diagnostically, therapeutically, to drain CSF and reduce ICP. And definitely we can place external ventricular drain EVD to monitor ICP and facilitate CSF drainage. And apart from these, we may have surgical decompression, decompressive craniotomies. In severe cases, it may be considered to relieve pressures. And in specific considerations for supratentorial tumors, like if we have vasogenic edema, so we may use steroids to treat these sort of edema that is due to tumors. Okay. For the use of anti-epileptics are frequently prescribed in patients are coming or undergoing supratentorial brain tumors. We may use them prophylactically to prevent seizures and therapeutically to control seizures. While prophylactic use is common, but before surgery, but there is no strong consensus on its effectiveness, and some studies suggest it may not significantly reduce the risk of seizures. In anti-epileptics, the commonly we used are the levetiracetam, phenytoin, uh, carbamazepine, that all are used as prophylactically. But as I have mentioned, that they are controversial, and some of the studies shows reduction in the seizure risk, while others do not. And we may use these anti-epileptics as a monotherapy.
Sorry to
uh,
interrupt, Dr. Sheharyar. Actually, your screen is not visible altogether. So if you can
okay,
just
okay,
share
okay, okay,
the slide show.
okay, okay, okay.
Slide share, or maybe the
Oh,
slide
okay,
share
okay.
option.
If we can just exit the presenter view and share the
Okay,
reference
okay, okay, okay.
presentation.
Let me restart my screen.
That's
Is
better
it
now. Thank
visible?
you.
That's better now.
Okay, okay. Thank you. Sorry for the inconvenience. Would you like to me to show you the previous slides, or it's okay if I continue with it?
I think that's okay. Thank you.
Okay, okay. Thank you. Okay, as we have discussed the use of anti-epileptics in supratentorial tumors, that their prophylactic use is not strongly, as there is no consensus over it, because some of the studies suggest to use them and others while do not suggest them to use as a prophylactic measures. And as I have mentioned earlier, we may use them as a monotherapy or in combination with other treatments, like with surgery, chemotherapy, or radiation therapy. Okay, one of the important concerns while a patient who is coming for the supratentorial tumors is arteriovenous malformations, specifically in the supratentorial region of the brain, where arteries and veins are directly connected without a capillary bed. This can lead to a neurological dysfunction either through hemorrhage, mass effect, or blood steam. And as a consequence, if a hemorrhage is in a subarachnoid space, so it may manifest as subarachnoid hemorrhage. If it is in intraventricular space, so it might be manifest as a intracerebral bleed. And this can be symptoms can be presented like a sudden or severe headache, seizures, and neurological deficits depending on the location and extent of the bleeding. And likewise, especially if they are large enough, so they can exert pressure on surrounding brain tissue, causing mass effect. And because of this mass effect, it can lead to compression of the brain tissue, potentially causing seizures or neurological deficits. Um, it is important to classify the arteriovenous malformations. So we use a classification that is known as a Martin classification. It used to assess the operability and predict the surgical risk of cerebral arteriovenous malformations. Uh, this system considers the size, location, and presence of deep venous drainage. And the goal is to provide a more accurate risk stratification for patients. So, if we detailedly discuss on the basis of the size, we grade them into three. If they are small, less than 3 centimeters, so we give them 1 point. If they are medium sized tumors, 3 to 6 centimeter, they can get 2 points. And if they are large enough, more than 6 centimeter, so they may score 3 points. And on the basis of the location, if they are involving the non-eloquent, likewise the areas that are not responsible for major functions, so they get 0 points. And if they are compressing or affecting the areas that are eloquent means the areas that are responsible for the major functions like movement, sensation, or speech, so they will get 1 point. In venous drainage, if they are superficial veins are involved, they get 0 point. And if deep veins are involved, they will get 1 point. So on the basis of this classification, we grades the arteriovenous malformations. If they are graded in 1 and 2, so they are generally considered low grade and often resected with lower rates of surgical complications. If they are involved grading as a grade 3, so these are the intermediate grade with a higher risk of complications compared to lower grades. And if they are graded like grade 4 or 5, so they are considered high grade and have higher rates of perioperative complications and lower rates of complete surgical removal. And they are some of the times they are graded as grade 6, that are inoperable. So definitely they involve the risk for surgery of such patients. So, in the intraoperative anesthetic goals for supratentorial tumors, we have to prioritize maintaining cerebral perfusion pressure and autoregulation. It means actually we have to ensure adequate blood flow to the brain tissue, which is achieved by carefully managing blood pressure, avoiding excessive increases or decreases in pressures, and maintaining a stable blood supply. In optimizing surgical conditions, it includes positioning of the patient appropriately, ensuring adequate muscle relaxation without interfering with neurophysical monitoring, and minimizing factors that could increase intracranial pressure. In facilitating neuromonitoring, it helps to assess the brain activity and function during surgery and anesthesia. It should be managed to minimize interference with these signals, because it allows surgeons to identify potential nerve damage or impairment before it becomes permanent. Um, we need to promote rapid and cooperative emergence. So we have to ensure a smooth and quick return to consciousness and alertness after surgery with minimal post-operative neurological complications. And if we talk about the specific complications and their management, so anesthesiologist must be prepared to manage potential intraoperative complications, likewise seizures, air embolism, and hemorrhage. Uh, in post-operative complications after supratentorial brain tumor surgeries can range from mild to severe, affecting both neurological functions and overall health. So, in the major complications, we have bleeding, hematomas, cerebral edema, and seizures. And other common issues includes post-operative nausea, vomiting, pain, hyperglycemia, neurological deficits, language or motor problems may also occur, and there might be hormonal imbalances like SIAD, and other systemic complications like DVT, pulmonary infections, UTIs, and meningitis, and other one like. Uh, as we are talking about the supratentorial tumor surgeries, so pneumocephalus is one of the major concern for the anesthesiologist as well and as for the surgeon, because the presence of air within the cranial cavity is a common occurrence after supratentorial craniotomies, particularly those performed for tumor removal. While usually asymptomatic and resolving spontaneously, in some cases it can lead to complications like headache, neurological deficits, especially if it develops into tension, pneumocephalus. The risk of pneumocephalus is higher in certain surgical approaches, such as those involving the front lobe or for supratentorial tumors. So, as we have discussed now for briefly the uh, right from the anatomy, and then with the preoperative concerns, and then with the ICP management, and then with the use of the anti-epileptics, and then definitely we undergo with the investigations that we need to have done before the surgical operations. And definitely, as per intraoperative complications we have discussed, likewise to control the ICP, to control the seizures, and to have a fine neurophysiological monitoring in place to check the sensory, motor, and visual and other pathways of the brains, because often the supratentorial surgeries are in the brain areas that control your vital functions. So it's very important. And even recently, the supratentorial tumor surgeries have get another fancy term, awake craniotomies. So these craniotomies usually have local blocks, and patient would be able to once you have opened the brain skull, and then your patient is becoming out of the sedation, and they are very much likewise and in the arousable sleep pattern, and they are communicating with the surgeon, and surgeon are very comfortable because they easily get know while they are intervening the sensory or motor pathways, so to prevent or to manage any complications related to these fine motor tracks or sensory tracks, because the surgical complications could lead to lifelong weaknesses or paralysis. So awake anatomy is one of the other fancy term that is used in the supratentorial tumors. So having discussed all this, one of the important, very important concern for the anesthesiologist in the emergence and in the recovery room, that their patients, if they develop seizures, as seizure can delay recovery and potentially cause complications. So their control is a critical in the management of supratentorial brain tumors. The optimal approach to managing seizures in this patient population, including the prophylactic use of anti-epileptics, but it's still being debatable. And apart from these anti-epileptics, all the other measures we have mentioned earlier are discussed would need to also in place, well in place, even before the surgery. We need to optimize for the ICP monitoring for any neurological deficits that are reported or diagnostic even before the surgery. So we need to have a uh, full diagnostic and therapeutic evaluations of the patients, so that post operatively we have minimize complications and have a smooth and early recovery of our patients. Thank you for your time. Presentations ended, and now you are open for your questions.
Thank you, Dr. Sheharyar. I would invite our participants to share the questions in the chat box. The floor is open for the comments as well. So,
Assalamu alaikum. Uh, Dr. Leena here. It was a very wonderful presentation, Doctor. I want to have, can you just let me know how you'd go for the open craniotomies, awake craniotomies rather, and just can you briefly sum it up? How do you go about it?
Thank you, Dr. Lena, ma'am. Actually, the awake craniotomy is definitely depend upon the over the surgeon views that they consider the patient for the awake anatomies, and for the anesthesiologist, they have to do the local anesthesia blocks for the such patients. So they may not have pain related to the skull opening or other issues. And once the patient is skull is opened, so the patient uh, is brought into the lighter plane of anesthesia, and often kept over dexmedetomidine or fentanyl, so that patient may able to communicate with the surgical team, so they have a minimize or almost no concerns for the to manipulate their these fine motor or sensory tracks. Awake anatomy is all about having a few blocks that are usually for the anesthesiologist to block the skull to scalp, and the other deep or shallow cranial nerves, like the greater occipital nerve, lesser occipital nerve, supraorbital, supratrochlear, and zygomatic-temporal nerve. So we need to block all these to have a wake anatomy.
So we
What do
also
you
have
use?
Dr. Leena. We also have, I think, Dr. Faraz Shafiq was here, and I think Dr. Dilip is also here. They do awake craniotomies on regular basis at AKU. We would like to have their mics unmuted so they can put in their comments. Dr. Faraz or Dr. Dilip from.
Brilliant.
Dr. Dilip is here, and he was also planned to have the invitation for the closing remarks, but we would love to hear from Dr. Dilip on awake craniotomy. Sir.
Thank you, Dr. Asma. It's a nice presentation. I must appreciate. For awake craniotomy, I noticed almost, I would say, in our hospital, we did in hundreds of cases. Definitely. The eloquent area is actually the speech area. And yes, of course, the sensory and the motor deficit. Really, it helps in a number of aspects. One, you are really preventing the deficit. Second is an early outcome and the patient satisfaction. Usually, the geriatric and old, they have an always fear of a neurological deficit. They really cooperate, and it's like a signal indicator for the patient and the surgeon in anesthesia to monitor throughout the procedure. Third is I would say, is a total perioperative outcome. The patient usually underwent for the awake craniotomy. Usually, they discharge in second and third post-op day compared to the general anesthesia.
So how do you
Because
guys proceed with the awake craniotomies at AKU
yeah,
regular?
I coming to it. So the fourth one is the benefit of that. Like the day after yesterday, we had a young 65-year-old lady, the big size tumor near to the eloquent area, almost a 6 by 6 centimeter, even the more than that. So she discharged after second day. So the blood loss, patient satisfaction, surgeon, and all that. Okay, how we proceed? The first and most important is I would say is the understanding for the patient. It's the first criteria. The patient is to be cooperative, can bear the surgery, and know about the surgical consequences and the steps he or she has to follow through the intraoperative. So this is really important because making a mind is important before moving to any procedure. Number one. Number two, really, yes, scale block, which we call analgesia. So we do a different practice, but my practice is still there are the three type of an awake craniotomy. You can go like in a awake, deep awake, and to go into um like in a awake, then to go into the deep. So, what the drug and how we use an scale block. A scale block, the body is given a different nerve that we all are familiar. We have a two supraorbital supratrochlear, which can be blocked with the one injection with the 2 to 3 ml of. We use a mixture of different our colleagues they are using. I use like an AMLA, really helps the patient. Even you don't require waiting time to settle the block. It's a really immediately act. I use a 3 ampulla for ropivacaine. One is a lignocaine, and other is a one ampule, which is a 4 milligram of dexamethasone and 60 to 80 microgram of epinephrine. So it's a mixture. Then you just take the syringes in a different, like in 2 to 3 ml per 2 to 3, 3 to 5 ml of a syringes. So go with the supraorbital supratrochlear, then the zygomatic temporal. From the zygomatic temporal, I would say because here is in a muscle. Muscle really needs an extra analgesia. So I go with the periosteum, above the periosteum, then the muscles, then the auriculotemporal, then go back on the lesser occiput, then the greater occiput. Right now, I am conducting a study in the even in, I do an intraoperative analgesia as an escape block for the patient. Really helps a lot, almost a similar outcome in the post-operative sedative effect and all that. Initially, we go for now. I am doing a research on it, RCT. We usually go for a bilateral. Now I move on the unilateral. The targeted nerves are being blocked. So we do an arterial line and the big larger size cannula. And we also use because of a central body and the patient is on the table for the 4 to 6 hours. The analgesia like intravenous, you can use an paracetamol. Anti-epileptic, what the doctor has told us, yes, really, we are using the same almost. Um, like in other, we use sometime a Presidex. Presidex really even the low dose propofol in the early settle of the block, when they come on the main part where the patient orientation and the patient monitoring is important. So then we are switching off every sedative. So because that's the goal of an awake craniotomy. So thank you, Dr. Asma. I think if there are any question, it's most welcome. I'm ready to answer.
So it
Dr.
was just a
Dilip,
small.
sorry, Asma, I just want to clarify a little thing. Dr. Dilip, if I understand correctly, that it's a combination of local blocks plus almost a TIVA. Is it so?
Uh, to some extent, it's TIVA. This is not the TIVA. It's actually we use a sedative just as an analgesic and to comfort the patient. Total intravenous anesthesia, not it's a sedation. You can say a sedation. Okay.
So for
Thank you
those
very much.
setups where fentanyl is not available, what are the other options for the awake craniotomies, like for the infusions, other than especially those who are having side effects of use dexmedetomidine, which is bradycardia or hypotension. So are there any other options which we can avail for awake?
Uh, sometimes, yes, there are so many options, depend on the user, how they are using actually. Like the young patient, they are very anxious. Initially, they're well prepared for the awake, but on the operating table, they really show the anxiety. What I do, I start a propofol sedation with the 50 to 100 miles per kg per minute and just go with the block and come on the point and talk to them. When they are walking through the propofol, they really are well coordinated. So one is to go for the propofol. And second is, yes, dexmedetomidine, Persidex. And third is a mixture of a midazolam. And you can use somewhere in the middle of some patients, even they are complaining for the pain after the block. It's like I would say is to challenge troubleshooting. So I use an albumin that really helps in, it's not preventing it helps in the analgesia also, not as sedative, but also maintaining the respiratory rate. Yes. Thank you.
Thank you, Dr. Dilip. So the question is from Dr. Ashraf. The first question is, do you use magnesium for seizure control and its prevention? And how about using phenytoin or Capra, which is levetiracetam, as anti-epileptics? Dr. Khalisha has asked this question. Dr. Ashraf, Dr. Sheharyar.
Sorry, I have muted my mic. Okay. Likewise, anywhere we have a problem with the seizure or fits, so we may use a range of medications like from the anti-epileptics and the sportive like the magnesium. So they are usable, and as I've mentioned in the presentation, that the most commonly are the levetiracetam and phenytoin, and you may use magnesium as well, definitely.
All right, so the next question from Dr. Dilip was drug of choice for pain management in your scenarios, Dr. Sharyar, for intra-op and post-op management, as well as how do you manage or deal with emergence delirium in geriatrics and obese patients?
Uh, Drug of choice for pain management, definitely for patient, depends on the patient factors, their age, disease process, and as they have mentioned that geriatric or the obese patients. But most of the time we use the one that is not dependable on the other organs, their elimination or their excretion from the body. So most of time dexmed and fentanyl and for the delirium and for these things.
Thank you, Dr. Sharyar. Queries regarding fentanyl and awake craniotomy has been addressed just recently. There's another question that from Dr. Jawad, that in an event of a sudden or severe brain swelling intraoperatively, what would you be your stepwise rescue protocol? And at what point would you be aborting the procedure to save the patient's life?
Sorry, can you repeat, please?
In an event of intraoperatively brain swelling, what would be your stepwise management? And at what point would you consider aborting that procedure or
Uh,
asking the patient to stop?
Okay, for the as I have mentioned in my presentation, for the ICV monitoring, even in the pre-operative or the intraoperative, definitely our stepwise management is with the osmotic diuretics, with the mannitol, the hypertonic saline, and in the intraoperatively, definitely we have a hyperventilation, and we may use magnesium, and definitely for the patient in the pre-operative setups, definitely we may drain the CSF through lumbar puncture, and we may place EVD, the ventricular drains, to drain the CSF. So definitely these sort of the modalities, from the pharmacological to the hyperventilation and then to the surgical craniotomies and EVDs.
Dr. Shreya, there is another question. If ketamine is totally contraindicated in these cases, or can we use the drug as an analgesic and in within the sedative dose?
Definitely, ketamine is not a drug of choice in where we have a problem with the ICP monitoring and other things. We may mostly are relying on the Dexmed and alpha 2 agonists most of the times.
Thank you, Dr. Shayar. I believe that would be it from the questions and the queries. If the participants still have any other query, they are allowed to have their mics open and have be a part of the discussion. Believe that would be it from our side. I would like to request Dr. Asma if she can have any closing remarks with regards to supratentorial craniotomy, ma'am, please.
Thank you, Abdullah. I think we have Dr. Leena here. Dr. Leena has also been the lead and chair at Ghurki Trust Hospital. So I would request her to have some closing remarks before we just close it off.
Thank you, Dr. Asma. And thank you, Dr. Sheharyar, for a wonderful and a very, very thorough presentation. And again, touching to especially awake craniotomy, which is so much new. And and thank you, Asma, for bringing up such good topics and such a good learning all over Pakistan. And I'm really pleased to have such a positive approach and such a good participation. I hope, inshallah, we'll continue with all this efforts, a combined effort. Thank you very much, and thank you, Dr. Sheharyar, once again, and Dr. Asma, and
Thank you,
Abdullah,
Dr.
of course.
Thank you, Dr. Leena and Dr. Sharia. We are really grateful to you for giving us this opportunity to have you online for the this topic. And I would request every participant to kindly fill in the kindly fill in the feedback form so that you can get the e-certificate from the PSA email address. And hopefully, inshallah, in 2 weeks' time, we will also get back to another new topic. And I'm really grateful to each one of you for joining us online at this hour at night. Thank you so much, Dr. Sharia, and thank you, Dr. Abdullah, for the coordination.
Thank you, Dr.
Thank
Asma. I would
you.
like to have Dr. Dilip. He has raised his hand for some queries. Dr. Dilip, the floor is open for you.
No, sorry, just a 1 minute. Actually, the two questions: how to manage a severe edema. Actually, based on the patient is all care is always based on not only anesthesia, as a surgeon, as a teamwork. I experienced the same patient like they started. Why always find out the cause? What was the cause for edema? Even we had a patient with a tumor with a large size, end up with it's a huge edema. Even it was not able to close the dura, and what we do, we have to take the patient intubated, ventilated in ICU. And I agree with the doctor. It's nicely presented how to manage the ICP. The same principle we have to apply, and then you come back again and to close the dura once the edema has been settled. Number one. Second, for delirium and obesity, I would say for the trainees, it's always challenging because when you go for the sedative, the neurosurgery, all and the edema and all that, really augment the patient sedation. Patient sedation again lead to the low respiratory rate and the raised carbon dioxide again is causing the cascade like an increase intracranial pressure. So please go with the patient, use your knowledge, but follow the patient. I would say at the end. And Dr. Saab has really described very well the site of lesion, size of lesion, and the duration of surgery, and mode of anesthesia, and the mode of your analgesic, and the anti-epileptic. So thank you, Abdullah. Thank you again for your time. Thank you very much.
Thank you, Dr. Asma. Thank you, Dr. Leena, Dr. Dilip, and Dr. Sharia for this comprehensive session on supratentorial craniotomy. Like to see you in the next session soon, inshallah. Thank you very much.